So good evening all. We'll start now in just a few seconds. Thank you so much for joining in on this wonderful new year, and be a lifelong learner, being a lifelong learner. So thank you so much everyone for joining in. We have with us Dr. J. Pillai. He is a B.Pharm, PharmD, MS, BCPS, and he is a board certified clinical pharmacist from St. Rose Hospital, Las Vegas. Sir, just wave your hand so that everyone can see you. Dr. J, if you can hear me.
Yes, Manoj, looks like my desktop screen.
No, it looks perfect. We can see you.
Perfect. Okay.
Yeah, we can hear you. We can see you. Your slides are projected on the screen. So everything looks perfect. So Dr. J comes with more than 25 years of clinical pharmacy practice in a hospital setting in the US and 7 years of academic and community practice in international settings. He is a global clinical pharmacy advocate. He is a passionate pharmacy professional who works towards achieving healthcare equity and expanding access for all. He loves teaching, evolving clinical pharmacy concepts, and he is our second speaker. He has spoken with us on community pharmacy and career opportunities for pharmacy professionals in the US. And today he would be speaking to us on the clinical review of physician's prescription prior to dispensing. This is a very, very important step, which might help us in preventing lot of side effects of the drug, plus helping us to plan for our pharmacovigilance activities, which is again very good concept which is picking up in India. So without further ado, I welcome Dr. J. Thank you so much, sir, for consenting and being present with us on this early morning in the US today on a Saturday on this new year. So I welcome you, Dr. J, and you can proceed with the session today.
Okay, thank you, Manoj. I appreciate the opportunity again for the third time. And I want to wish you and all the participants for a very happy and wonderful new year. And I hope the year 2022 brings some kind of normalcy from this nasty pandemic, particularly the new wave of coronavirus, Omicron. Hope it subsides and hope we all can go about with our normal lives. I wish you all the very best.
Thank you.
We wanted to present some series of webinar with the help of Manoj, particularly in clinical pharmacy, that helps you prime the topic as a clinical pharmacist. In my world here, clinical pharmacist doesn't mean just the PharmD. Any pharmacy professional, B.Pharm or M.Pharm, who has the experience and the certification to be a clinical pharmacist. When I began a clinical pharmacist in this country, I had my degree from India. Then I had my master's in pharmaceutics from New York. Then I looked at all these PharmD people here, a new branch of pharmacy profession, clinical pharmacy. Then I did my PharmD as well through one of the colleges in Pocatello, Idaho, just to have some satisfaction and completion, I guess, for myself. So this series begins with this particular topic, clinical review of physician's prescription prior to dispensing. What I'm going to talk about is really applicable to this country, the US, and from where my experience comes from mostly. although I have been a pharmacist back in Middle East in 1983 for about a few years, where also I have dispensed a lot of prescriptions. Now it is quite advanced. So the procedure that I'm going to discuss with you applies to what we do here, which could be emulated or practiced, in course of time. It's going to be too early to follow this process completely as we do here, but we can definitely, take those points and apply those principles to practice back in India. Let's jump to the first slide. The webinar objectives. First of all, I will go through types of medication errors. There are very many different types of medication errors coming from the physician and also coming from even the patient and also coming from pharmacist and also coming from nurses. But we will focus particularly on prescribing errors, the prescription errors that comes from physicians to the pharmacist first. We are the first point who has the opportunity to see the prescription and check the prescription before it goes to the patient. And I'm going to, it's not a guidelines, some suggested recommendations how to review a prescription. And I'm going to give you some examples of a prescription that comes to our community pharmacy here in the US, and also another patient in a hospital setting. And these two patients both have the UTI, infection, urinary tract infection. And that's why we need to probably go through a little bit of the pathophysiology or the pathogenesis of the urinary tract infection, and also how to present the information to the physician, the communication skill that we should gradually develop so that we can give the proper information in a proper fashion so that the physician who prescribed the drug is able to accept the interchange or the recommendation that we make. And finally, we will end up with the Q&A session. Is everybody able to hear me clearly?
So guys, if you can hear Dr. J, please type Y in the chat box. And if you're not able to, then type N. So we'll just know. Yeah, perfect. Thank you, Dinesh. Thank you, Nagaraj, Guru Kiran, Nutan, Lakshmi. Thank you so much. So everybody can hear you, sir. Perfectly fine. Go on, sir.
Excellent, excellent. The second slide, as you can see, the types of medication errors that we would encounter in the process of, dispensing medications. If you look at the pie chart, the circular pie chart, the prescribing errors accounts for 46%, which is the major area. It's a major slice of the errors that comes from physicians' prescriptions. And also the administration error from the nursing side, if it is in a hospital setup. And also you can see the transcribing error, which is about 10%, which is the process of transcribing the prescription information, usually on the chart by the nurses or by someone else in the hospital who is taking the prescription orders from the physicians. You can also see the dispensing error, which is by the pharmacist, which is 14%. Although it's not as big as the prescribing error, the dispensing error is quite a bit, 14%. So that's where we come in, and this presentation is going to help you minimize those dispensing errors. So let's go to the next slide. How to review a prescription. And these are some of the guidelines or recommendations that we follow while getting a prescription and looking at it before dispensing a prescription. First of all, we have to know, at least we should have an idea, is there an indication for the drug? You're getting a prescription for amoxicillin or a blood pressure medication or something for arrhythmia or something else. We should be able to have an idea as to what it is prescribed for, the indication, the use. And the next one is the medication prescribed appropriate for the indication? You're getting a prescription, you know what it is, you know what is the indication, but is it appropriate? That would be the second point of check. When we go through some of the prescriptions in the following slides, you should be able to understand what I mean by appropriate for the indication. And is the dosage correct? That's the third step. If the prescription has amoxicillin in it, and there is a strength, 250 milligrams, 500 milligrams, is the dosage, that particular strength, is correct for that particular patient? We need to take a look at that. And also, are the directions correct as well? If you have an antibiotic, Cipro, for example, 250 milligram, once a day, it is not an appropriate directions. Usually, Cipro is prescribed twice daily. And also, are there any clinically significant drug-to-drug interaction? A patient comes in, present a prescription which contains, for example, a calcium channel blocker, verapamil, and also at the same time, the prescription has digoxin in it. There is a drug interaction between verapamil and digoxin. We should be able to recognize, and we should be able to make some recommendation to either eliminate the drug interaction or minimize that drug interaction. Are there any clinically significant drug-disease interactions? Not only between drug and drug interaction, we should take a look at it. We should also be able to identify if there is an interaction between the drug that is prescribed and patient's disease condition that kind of interacts with the drug. For example, patient comes to our drugstore or comes in a hospital, patient is taking albuterol inhaler, which is given for asthma, for wheezing, and the patients develop hypertension, and the patient brings in another prescription for propranolol, Inderol, for example, which is a non-selective beta blocker. There is an interaction. A non-selective beta blocker is going to worsen the condition of asthma. So that is probably not an appropriate beta blocker to this patient with an asthma, because it is going to make the condition of asthma worse. So we should be able to identify that and contact the physician to recommend some alternative, such as a selective beta blocker like atenolol or metoprolol, or a totally different antihypertensive medication such as lisinopril, an AC inhibitor. Is there a necessary duplication with other drugs? Duplications are the worst thing that we as a pharmacist very often miss. The patient is taking for UTI some antibiotic, and then after about 4 or 5 days, patient goes back and develops fever and go to a different physician, and he prescribed another antibiotic and comes to a drugstore or the hospital. We should be able to see that, hey, this patient is on an antibiotic already. there is another antibiotic. What's going on? We should be able to check that and contact the prescriber to clarify that. Is the duration of therapy acceptable? You are getting a prescription again, reference, antibiotic. It's a cold season. You develop some kind of a nasal or respiratory infection. Doctor prescribes a simple antibiotic like Cipro or amoxicillin. Is the duration is good? Is it for 5 days or 7 days or 10 days? You have to check that. Most of the time, physicians tend to prescribe 10 days, 14 days, which may not be appropriate for certain type of infections. Most of the infection clears within 5 to 7 days, unless the patient has some complicated infection involving multiple drug-resistant organisms, MDRO pathogen, multiple drug-resistant organisms, because you would have seen some of the clinical pharmacists in the audience in the hospital. There are a lot of multiple drug-resistant organisms nowadays and coming into the picture, like ESBL, E. coli. ESBL meaning extended spectrum beta-lactamase resistant organisms. These organisms will be able to destroy any cephalosporins, any penicillin antibiotics. They have the ability to destroy the beta-lactamase ring in that antibiotic. Once they destroy the antibiotic, that drug is not going to be effective. So those are all multiple drug-resistant organisms. In those cases, sometimes doctor do prescribe for 2 weeks, sometimes even for 3 weeks, because the organism is so resistant. You got to use a different antibiotic, sometimes combination of antibiotics. So it's important that we look at to make sure the duration of the therapy is acceptable for that particular antibiotic, for that particular indication. And finally, not the least, is this drug is least expensive alternative, because everyone is not rich. And there is an antibiotic, alternate antibiotic, which is less expensive, pennies on the dollar, paise in rupees. Then if that antibiotic is as good as an expensive one, we should be able to make that recommendation and make sure the therapy is also cost effective. I'm kind of thirsty this morning, Manoj. We drink some water.
Please, sir. You just reminded
Before
everyone.
we get into the, is it good?
Yeah, it's good, sir. You just reminded me to drink water.
Please do, yeah. Hydration is always good. Hydration is also good for UTI, by the way.
Now, the reason you have a call here today is to inform that each one of you have to deliver 5 girls.
I'm sorry, there was some mic on from one of the attendees.
Yeah, some Professor DK, someone.
Yeah, I just muted. I muted.
Yeah, please, sir. Thank you. Yeah, if you have any questions, we will discuss that. Not a problem at the end of the discussion.
Absolutely.
Now, because the patient we are going to be discussing about has UTI, urinary tract infection, which is very common, particularly in females. Of course, male also get the infection, but not as much as females. How does UTI comes about? The pathophysiology or the pathogenesis. The UTI occurs in the genitourinary system, which can involve kidney, ureter, bladder, and urethra. And the urinary tract is normally sterile. It does not have any bacteria. But what happens, the gut bacteria, the bacteria that lives in our gut, in our GI does get into urinary tract system. And the defense mechanism that the genitourinary tract has is complete emptying. Although there is an infection in the bladder at the bottom, when you do complete emptying, those bacteria goes out and it is not an infection. And urinary acidity also provides to prevent infection. And also if there is some bacteria in it, the acidity will be able to destroy the bacteria. And the third one is vesico-urethral valve. This valve that is present in the system does not allow the bacteria to reflux or go back into the ureter, into the kidney. It's kind of an one-way drainage of the urine, and there are some valves built into the tract. So the valve allows one way for the urine to drain into the bladder. And of course, the urethra, the surface, and the urinary tract does have some immunologic property and also mucosal barriers that prevent infection from staying in the bladder or in the ureter. And most of the UTI, 95%, is because of the ascension of bacteria from the urethra into the bladder. Where does the bacteria comes from? Mostly it is E. coli. You would have heard of that, right? E. coli infection, Escherichia coli, E. coli infection, that travels from feces flora, from the rectum into the urinary tract. Because the gut bacteria goes into the large intestine and into the feces. And when the feces comes out, because of the hygiene and the ability to not clean the area properly, the E. coli finds a way from the rectum into the urethra and goes into the bladder. As long as the bacteria, the E. coli, stays in the urethra and into the bladder, it is simply a colonization. It's simply they get in there and stay there. It's not an infection. Colonization is not an infection because it stays there, and because we are able to empty the bladder completely, and there are some urinary acidity built in, those bacteria, either they are killed or they are emptied when we go for urination. What happens when the large amount of colony of E. coli is present and it starts growing, and if you don't drink enough water, and also if you don't empty completely, then the urinary tract here from the bladder to the ureter, the bacteria starts ascending, starts going up. So 95% of the UTI is because of the ascension of the bacteria from the urethra to the bladder, and then it starts ascending into the ureter slowly because too much growth is taking place, not being emptied. Very often, the patient is not drinking good amount of water. So it goes into the urethra, and then it can get into kidney as well. So as long as the infection is in the lower part of the urinary tract, it's called as lower UTI. And if it goes into the upper part, into the kidney, then it's called as pyelonephritis, which means simply kidney infection. So usually the UTI in the lower part is called as uncomplicated UTI. There's not much complications because it can be easily treated because it is the infection stay in the lower part of the genitourinary systems. When the infection ascends and spread into the kidney, then it is a complicated UTI. What we are going to focus right now is on the uncomplicated UTI. The assumption is the infection stays in the lower part of the UTI, just in the ureter portion here and in the bladder. Now let's go into a community setting prescription. I have to assume that we don't have a sound and a clean clinical practice in a community setting in India. I was reading one of the Manoj's posts recently that a lot of these community pharmacies, we call it medical shop, right? They do have mostly diploma in pharmacy candidates. With all due respect, those diploma pharmacists are the pillars of the community pharmacies. Even when I was there back in India, my brother was a diploma in pharmacy. He used to work in a hospital and then some part-time in a drugstore. This part applies mostly from my point of view and our practice here in the US. It's a community drugstore setting. A patient brings in a prescription for amoxicillin, 250 milligram Q6H every 6 hours, no refills. And also in the same prescription, we happen to see a low estrogen once a day from day 1 to 28 with some refills on it. This comes from Dr. Yadav clinic, who is very famous in Bangalore, treats a lot of patients, particularly patients with infections. He is doing some specialty practice in infectious disease. This lady, Ms. Sunshine, is a relatively young lady, 30 years old, brings in a prescription to me. When I look at the prescription, a couple of things stand out immediately for me between the two drugs, amoxicillin 250 milligram, and also the low estrogen, which is a birth control pill. What we usually check first, the indication. I know by looking at the prescription, amoxicillin is used to treat infection. And also I need to look at the effectiveness of the antibiotic that is prescribed. And is it correctly dosed? Is the direction correct? Is there a drug interaction? Is there a duplication? Is the duration of the antibiotic is written? And is it correct? And also the cost effectiveness. In general, we try to look for these points very quickly. By talking to this lady, Sunshine, it appears she has a lower, uncomplicated urinary tract infection. And also, she's also taking a birth control pill because she doesn't want any more child. First, the UTI, the patient told us, I have an UTI, urinary tract infection. The doctor prescribed this. So there is an indication, and the drug prescribed is appropriate. It will be effective for UTI because from the way I gather the information, it is in the lower part. It is not a complicated UTI. And the dosage, I got a spelling mistake here, apologize. Dosage written is 250 milligram Q6H. And I can see the strength 250 milligram as usually is not a sufficient dose to treat an adult patients. Usually 250 is limited to adolescents, children. For adult, the recommended dose is 500 milligrams. And the direction is every 6 hours. It should be Q8H. So already I have identified two issues. One is the strength it has to go up to 500 milligram, and the duration is Q6H. It's actually dosed as Q8H every 8 hours. And the second issue I'm identifying is the birth control pill. When they take it once daily, when they take the antibiotic is interact with the low estrogen. It's a drug-to-drug interaction, makes this birth control pill ineffective. So she may get pregnant, which she doesn't want. So these are the issues, particularly from this prescription, I can identify from the information, limited information that I have in my computer, and also by talking to the patient. So I'm calling Dr. Yadav, explaining the situation. And he is a gentleman and a scholar. He is very receptive to clinical recommendation coming from clinical pharmacist. As a result, he is accepting our recommendation, and he is giving a new prescription, and he is actually allowing you to change the prescription to amoxicillin 500 milligram Q8. There was no duration as well, and usually amoxicillin, when it's given for 5 days, it's more than sufficient to eradicate the uncomplicated UTI. And the low estrogen is an issue, and it is up to us to counsel the patient, explaining the situation. Hello, ma'am. When you take this antibiotic, it's going to do good for you. It'll clear infection, but it can impair the efficacy of the birth control pill. So it's better that you either abstain from romantic activity, or you can follow some other additional birth control options, like having your partner, husband, use a condom. That would be our recommendation if you would like to follow that, unless you want to abstain, during for about a week or so, a couple of weeks, abstain from any kind of romantic interlude. So we need to counsel the patients and send her home. So that's one of the approaches that we do here in a drugstore. And I'm not sure this can happen or it's happening in India. I would like to hear from either Manoj or from the audience what's going on back in India, and how can we take steps to improve the situation.
So right now, in many hospitals, especially the bigger ones who have employed PharmDs or clinical pharmacy professionals, they are following these practices, and they're also following, the specialized softwares which alert the clinicians on drug interactions. So in many hospitals like Fortis, Max, Manipal Group, they have the specialized softwares, which is, through SIMS, and there are other softwares also. So they take care of the drug interactions at the first level. And the clinical pharmacists, of course, PharmDs and other MPharm clinical pharmacy professionals are also helping them a lot. But then, lot to be done. This is just the beginning. Yeah, lot to be done.
Yeah. I think particularly in a drugstore setup, it is important that they change the law or some kind of an intervention from, the higher authorities to have a clinical certified pharmacist in the drugstore, physically present all the time to guide the diploma in pharmacist people prior to dispensing the medication. But like Manoj said, it's going to take a long time. At least I'm glad to know that hospitals are much better adapting this process than the drugstore setup.
Sir, it is only the beginning, sir. Only few hospitals and the bigger ones have adopted this. But at the
Yeah.
ground level, the situation is not, cohesive with respect to patient counseling and medication
Yeah.
recommendations from a pharmacist. As usual,
Right.
we have diploma in pharmacy at the retail level, and they are not allowed to, substitute or give a, prescription recommendation. So it is
I
not
see.
happening at the ground level, but yes, a lot has to be done. And of course, with our kind of pharmacy professionals today, they are, very aware and they know their duties very much. If they take control, at the ground level, possibly things will change. So let's hope for the best and see, how our clinical pharmacy and the PharmD specifically are able to contribute to this.
I see. I'm at least happy to hear that there are some big hospitals recruiting clinical pharmacists. I guess those hospitals that can afford to employ a clinical pharmacist. It's all, cost and benefit kind of situations
Yes.
at the expense of the healthcare for the common citizens. I'm hoping at least we are on the right track and it'll keep improving upon it. Let's go to the next setup, which is that we are going to review a prescription in a hospital setting, which I do on a daily basis because I'm kind of semi-retired. I go to the hospital probably once a week or twice a week. And this is purely in a hospital setting. Mrs. GM is a 70-year-old female weighing 58 kilograms, 64 inches height, 5 feet and 4 inch, admitted for a complaint of suprapubic pain, dysuria, meaning, of course, you would all know, painful, burning sensation when she urinates, and also frequency of urine. This actually, from the description of the complaint, I can pretty much make an educational guess that it is an uncomplicated UTI because the pain is limited only just above the bladder area, suprapubic pain, and painful burning urination with the urinary frequency. The pain is not permeating up and to the back, which might indicate the infection has ascended to the kidney. And she has allergies to penicillin and codeine. I'm just giving you a brief history, an abbreviated history of the patient, which I'll be able to see it in the computer. So I have all the information available to me to make a better assessment and a better recommendation if one is needed, which is not available in a community drugstore setting. The past medical history is that the patient has hypertension, diabetes, hypercholesterolemia, ventricular arrhythmia, and osteoarthritis. These are her past medical history. She has all these medical conditions. And the current medication is aspirin, enteric-coated 81 milligram once daily. And I have given you the purpose of the use of the medication, which is an antiplatelet. Losartan, 50 milligram with hydrochlorothiazide, 12.5 milligram once daily for hypertension and diuresis. Atenolol, 25 milligram once daily for hypertension and rate control. Amiodarone, 200 milligram once daily for rhythm control. Metformin, 500 milligram, extended release once daily, combined with glipizide once daily for diabetes. Pravastatin, 40 milligram at bedtime for cholesterol because patient has hypercholesterolemia. And acetaminophen, which is your Tylenol or paracetamol 500 milligram 3 times daily. That's for osteoarthritis because patient has the osteoarthritis. Multivitamin with minerals once daily, vitamin supplements, which is good. Cyclobenzaprine, 5 milligram at bedtime because she was complaining of some muscle spasm as needed basis, along with alprazolam, 0.25 milligram at bedtime as needed for insomnia. When we see this medication list, we should be able to assess the appropriate indications for which she is taking. A quick review of the medication profile, just making sense of her past medical history and combining with the medication, then we can come to a conclusion that these are all appropriate medication for the appropriate indications as indicated above. Any questions? If they have, please make a note of that. We will discuss that, after the completion of the few more slides.
Absolutely, sir. Yes.
Yeah. Just concentrate on the bright yellow portion of the slide. Complying is suprapubic therapy, dysuria, urinary frequency, and penicillin allergy. And I put osteoarthritis highlighted because acetaminophen is the right drug for osteoarthritis. It is taken on a daily basis, 3 or 4 times daily, not as needed. And the next slide continues from the previous one, the patient history. You can see the labs and culture and sensitivity in our computer when I'm reviewing this prescription and the patient history. Labs, CBC is the complete blood count, and electrolytes like sodium, potassium, calcium, magnesium, chlorine. These 2 aspects of the lab, complete blood count, like weight count, RBC, platelets, and this particular labs are within normal limits. WNL is the abbreviation we use, within normal limits. I have not given the lab details because of the space constraint and the real estate I have on the slide. And the vitals, her BP, blood pressure, is 115/75, which is normal blood pressure. And the heart rate is 77, which is also normal. And her temperature is afebrile. She doesn't have any fever. So that also gives me additional clue that it is an uncomplicated UTI. With a complicated UTI, patient may have usually some fever. And the WBC, the weight count, is 9.5, which is also pretty close to normal or slightly elevated. And the respiratory rate, the breathing rate, is also normal, 16 breaths per minute. And her kidney function, I'm looking at it, serum creatinine is 1.1, slightly elevated. Usually the normal is 1 or 0.9. It is 1.1 because of her frequency of urination and the infection that she has in the bladder. She is not able to drain the urine properly. That's why the serum creatinine indicates that she's not urinating completely. That's why it's elevated to 1.1. And the creatinine clearance is 40 to 45 mils per minute. Usually, the creatinine clearance is anywhere between 80 and 100 to be in normal range. Now it is reduced because of her inability to empty the bladder. Urine is slightly hazy, indicating an infection. And the test by dipstick is positive, which means patient has some microorganisms, bacteria. And the urine culture indicates that E. coli is growing at a concentration of 100,000 per ml. Each milliliters has 100,000 of the E. coli. That's called a CFU. So it is growing, which means this confirms that patient has an uncomplicated UTI with E. coli. Then we need to find out appropriate antibiotic that the lab does, and this is the culture sensitivity. The E. coli is sensitive to different antibiotics, which is a good news. Levofloxacin, sulfa drug, the Bactrim DS or Septra DS, I believe we call it as a brand name, amoxicillin, and nitrofurantoin. We have got quite a few antibiotics to choose from. The question is, we have got to choose an antibiotic that put a check mark on all of us, all of our pointers that we discussed as to how to check our prescriptions, whether it's appropriate, does the job, whether it is cost effective, and every pointers that we discussed in the previous slides. And they also did some kidney ultrasound to make sure there is no any abnormalities in the kidney structure, just to rule out the complicated UTI part of it. And there is no abnormalities on the kidney, which is good. And also there is no renal calculus identified. They did not identify any kind of issues with the formation of stones in the kidney. So kidney shows that it is in good shape. And of course, the diagnosis, ultimate diagnosis is uncomplicated UTI, which the doctor decided, which appears to be correct from my point of observation. And the doctor prescribes ciprofloxacin, 500 milligram twice a day for 10 days. Now, by looking at the information we discussed in the prescription for community setting, and also the information that we have on patient, which is a good amount, give us more clear picture to make an assessment of the appropriateness of this particular antibiotic. Is it an appropriate drug? Does it check most of the boxes that we discussed? Manoj, is it possible to ask the audience yes or no question?
Yes, sir. We can ask, sir. Yes, sir. We can ask.
Yeah. Hello, friends. Would you be able to indicate by putting S for approving this antibiotic prescription, or no for not approving this particular antibiotic? Very quickly.
Friends, you can just type yes and no in case you feel that this can be prescribed.
What amount of yeses as opposed to no's, Manoj?
So there is no yes as of now. There is only one yes, two yes, and majority is no.
Excellent. I'm glad to hear that. You're able to identify, most of you, that it is not an appropriate regimen. Look at the culture sensitivity. Of course, it is sensitive for levofloxacin, which is a fluoroquinolone, and Cipro belongs to the same family. It's going to be effective, but the dose and the direction and the duration, all of them are not appropriate according to recommendations. Why? Because patient's serum creatinine is 1.1 and creatinine clearance is compromised. It's actually 40 to 45 mils per minute. So in these situations, if you give ciprofloxacin 500 milligram twice a day, it's going to be a large dose. Patient is not going to eliminate the metabolized drugs easily. Usually, in a patient with this kind of creatinine clearance, ciprofloxacin is given once daily. You have to reduce the dose based on the patient's ability to clear the drug. Otherwise, the drug is going to accumulate. It can cause side effect. That's one. Number two, this drug is, I believe, is an expensive drug too in India. When you have a lot of less expensive drugs like nitrofurantoin, Bactrim, and amoxicillin, why would I choose an expensive antibiotic? That should be a question that we need to answer. If it is given, this drug is going to work, the appropriate dose of this particular drug for this patient with a compromised creatinine clearance is going to be 250 milligram once daily for 5 days. That should be the dose, direction, and the duration. 250 milligram once daily for 5 days would have done the job. And also, I'm noticing that there are other antibiotics which are less expensive. Sulfur drug, and amoxicillin, and nitrofurantoin. If you recall from the information that we got from patient's allergy, patient is allergic to penicillin, so you cannot give amoxicillin. So other two alternatives are sulfur drug and nitrofurantoin. You could choose either one of them, actually, between sulfur and the nitrofurantoin. And one more thing, the fluoroquinolones is not recommended for patients over 60 and above, because elderly patients may suffer a side effect such as tendinitis. It has been documented that Cipro causes quite a few side effects in elderly patients, like tendinitis, inflammation of the tendons. They will complain of joint pains, tendon pain. Also, when you give in such a high dose, Cipro can also cause C. diff infection in the stomach. Clostridium difficile is one of the bacteria that grows in the stomach when we take antibiotic like this in high dose, causing constant diarrhea. So we go to treat patients' urinary tract infection and give this dose unchecked and dispensed, which is causing an additional problem. Patients coming back with constant diarrhea. The patient also can develop, because of the fluoroquinolones, has been documented to cause QT prolongation. We did notice this patient has arrhythmia and taking amiodarone for arrhythmia. The patient has some heart problem, rhythm problem. So this can add to the problem, causing QT prolongation, which is a serious medical condition that can cause for the patient to be admitted in the hospital again. Those of you who are not familiar, students with QT prolongation, you might want to Google it and study later. It is cardiac arrhythmic abnormality that comes about, which could be a dangerous condition. So ciprofloxacin is definitely not an appropriate antibiotic for these patients. What we decided as a clinical pharmacist, me in the hospital, I chose sulfa and trimethoprim because this drug is not only very appropriate for uncomplicated UTI, it can eliminate it. Amoxicillin is not appropriate because patient has penicillin allergy. Nitrofurantoin is also appropriate, but the patient is over 65, I believe 7 years old. So nitrofurantoin sometimes can cause pulmonary issue, pulmonitis. So I went for sulfa trimethoprim, which is not only a better antibiotic, it can also be very less expensive. And that's what we are going to recommend to the attending physician for this patient. And we need to communicate with the prescriber, which is an important aspect in this process as a clinical pharmacist. What we need to do to develop some qualities and communication skills. To do a better communication skill, you have to establish a very congenial and collaborative relationship. It is actually a collaboration between the healthcare providers. We are one of the healthcare providers in the best interest of the patient. Patient has to get the best treatment. And there is an equal interest for the physician as much as I have. So try to establish a very cordial and collaborative relationship first and foremost. And when we talk to the doctor directly in a hospital on the floor, we got to display a professional look and a friendly demeanor. It's important that we dress up nicely in a white coat, better appearance, professional appearance, and also our approach has to be very friendly. I have seen some of the pictures, no judgment. Some of the clinical pharmacists, they got some stethoscope on their neck. I'm not against it, but it may not project a professional look because, in my opinion, without judging anybody, stethoscope is not my area of expertise. Of course, everybody can use a stethoscope and hear the heart sound. But when a physician looks at you with a stethoscope, we are projecting an incorrect image of ourselves. We are not physicians. And I would like to think I'm no less than a physician either. We are equal partners in offering healthcare to the patients in both best interest. Of course, one can argue, I can identify, trouble that I hear from the heart sound, like murmur, this patient heart rate is extremely high, tachycardia. The pulse is something like 50, possibly a bradycardia. We can probably argue, but that's not our turf. Our turf is simply medication therapy optimizations. That'll be my friendly, humble presentation to the audience without any judgment. And when we talk to the physician, we have to exude confidence. We should project confidence. We should look confident and competent with some sense of humility. It's no place to display any kind of disrespect, disregard, or looking at the doctor with a condescending look because he has prescribed an inappropriate antibiotic. You may do that if that patient happens to be your father or your mom. Hey, doc, what are you prescribing? Are you trying to kill my patient, kill my dad? What I'm saying is that even in those cases, it's important that we still be professional, still be friendly, speaking to him confidently with a sense of humility. And when we provide information, we've got to be informative and suggestive. Suggestive is an important word. You got to make it as a suggestion, not as an order. Hey, doc, this drug is incorrect. You have to use this different drug. No, we got to be suggestive. You got to say, hello, doctor, I went through the profile. Patient has E. coli infection, and the culture sensitivity shows sensitive to different antibiotics. These are the issue with ciprofloxacin. I can provide you the evidence. In that manner, you got to be quick, informative, and suggestive, concise, and respectful. And if the doctors, sometimes the doctor, try to argue, after all, it's a wall of worry, the doctors, place we are kind of trying to encroach upon. That kind of feeling still present in some of the physicians, even in this country. So when they try to argue and talk back on why he or she chose that medication, you have to listen that carefully with an open mind. They may have some point. So as opposed to a closed mind, we better listen to them actively. That's important. And also when we start making very small interventions, impress upon the physicians, and we can build quite a few successes on that. And finally, regardless of the physician's acceptance, sometimes physicians may not agree with your recommendations. Sometimes they may reject it. No, I want Cipro only. I have a lot of experience. In spite of your explaining the reasoning, the logic, and providing the references for those recommendations, still thank them. Thank you, sir, for giving me the time. Appreciate it. And then you document that conversation in the chart somewhere. Here in the US, we can document. I presented the alternative antibiotic for the following reasons, and the physicians declined accepting the interchange because US is a very litigious society. Anything goes wrong later on, this can come back and bite the person who is not doing the right thing. And also we have to safeguard ourselves. That's what we do. These are all some of the pointers so that you'll be able to develop a good communication skill. And also we should be able to speak the language. So we have to practice. When I left India, I don't think I was able to speak that fluently. I was a lecturer in Manipal. That's when I began speaking English. But I gradually improved, but still I'm improving on that aspect. Now, when I spoke to the doctor in a hospital setting, providing reasoning, evidences intelligently with confidence and humility, he did change the Cipro 500 to Bactrim DS, 1 tablet twice a day for 3 days only, because it is an uncomplicated UTI. And see the dosing is 1 tablet twice daily and only for 3 days. 3 days is more than sufficient to kill this in a UTI. There are some E. coli. It's coming up recently, developing resistance like ESBL that I mentioned, extended spectrum beta-lactamase inhibiting E. coli. So we cannot use any of these antibiotics. There are different antibiotic that could be used in place of that. That would be a different discussion by itself. So for now, let's complete the prescription review of 2 patients with uncomplicated UTI and how we can go about changing those antibiotics, making recommendations, and finally, that'll do good for the patient. And final, in summary, every prescription order requires a clinical review. It's a must. Dispense only when all the safety criteria are met. We have to check most of the boxes, and then contact the prescriber to clarify inconsistencies like a dosing, strength, duration, and all those things. When in doubt, call the doctor for clarification. Be professional, polite, informative, and concise with physicians, as we discussed. Of course, we need to document the outcome of our conversation, regardless whether the physician accept or decline. The obvious point is the patient safety is our primary goal. And that completes the presentation. And Manoj, if you can let the audience present any questions, concerns, any comments, I would be happy to indulge in.
Absolutely, sir. Thank you so much, sir, for this wonderful presentation. Sir, may I request you to close the slideshow? Excellent. Thank you, sir. So, dear friends, I'm sure you would have got an overview of the basic prescription audit through Dr. J. I hope today's session provokes some positive thoughts and helps us embracing the prescription audit with the sole intention of preventing drug interaction and helping our patients recover faster with least side effects possible. And I must thank Dr. J for pointing out the stethoscope, point used by the pharmacy professionals in India. And it has been, actually a matter of pride for most of the, pharmacy professionals who use stethoscope and pose as a photo in the photo on the social media. But it for sure dilutes the professional image of a pharmacist. We are supposed to be the medicines expert and not the disease experts, right? So we are supposed to be helping people know our profession. And I must thank Dr. J for pointing that out. I hope our pharmacy professionals take this positively. Now we shall take up some questions. Please raise your virtual hand on Zoom and I'll unmute you so that you can ask the questions. Yeah, so Professor Gyanachandran, you would like to unmute yourself. Please go on.
Hello, good evening, Mr. Manoj Kumar Yadav. First of all, I wish you a happy new year. It was a very excellent clinical presentation by Dr. J. Really, given about this bacterium is very well ideal for this urinary tract infection. I put 2 or 3 questions, but the way he presented, I would like to appreciate our pharmacist colleague, because we are not doctors. We are pharmacists. We have a limitations, but we have to help doctors to give the best medication and optimization of the medical treatment. Really, thank you, Dr. Manoj and Dr. J. Pillai, and behalf of this new year and all the pharmacy professors of Indian colleague. That's very good presentation. Thank you very much. Thank you, Dr. J. Pillai.
Thank you, sir. Thank you so
much.
Thank
you, Dr. AK. Appreciate it, sir. Anytime, it's my pleasure to indulge in these activities through Manoj. He gave me the opportunity, and we are going to keep doing it as best as we can. Any professional organizations, School of Pharmacy institutions, if they have any topics, they can send it over to Manoj or me, so that we will be able to pick those topics that will be of extreme use to the hospitals or School of Pharmacies or any other entity. That's our goal for this year. Thank you so much for your comment.
Absolutely, sir. Absolutely, we'll do that, sir. Thank you so much, sir. Thank you, Professor AK, sir. Divya, would you like to unmute yourself and ask the question?
Hello, sir. Am I audible?
Yes, very much, Divya.
Okay. So my point was the session was extremely informative, and I felt like recollecting all my college lessons from this session. Thank you so much, sir, for their knowledge sharing and bringing out the role of clinical pharmacist in general. But the scenario in India is not what as you explained in your presentation, because I am a doctor of pharmacy graduate. I graduated in 2018. And when I graduated, there were only, maybe 3 or 4 doctor of pharmacy batches which had come out. But now, maybe around 10 batches would have come out. But even now, the role of PharmD, that is Doctor of Pharmacy graduates, is not very much understood in the clinical scenario. Like post-college, I went to the corporate sector and I had to take up a different role there. So I was not able to come into the clinical sector. I was much interested in the clinical sector, but due to the scenario, I had to move to the corporate sector. But now in this COVID pandemic scenario, I'm feeling like I need to come into the clinical sector to help the public and the suffering patients. So I hope that better changes come in the clinical pharmacist sector in India, to see like the role of pharmacist. The ideology behind a pharmacist is being understood by the doctors, particularly the doctors and the practitioners. They don't like back in 2018 and before that, when I was in college and when I was doing my internship, when we used to report to the physicians the medical errors, the prescription errors which they do in the prescriptions, they never mind. They just ignore us like, who are they to tell us? They are just pharmdies. Who are they, like that? They don't. We didn't ask for the respect or anything, but they have to consider us at least for the patient's benefit. But that was not given to us. Maybe in 3 years' time, maybe something should have changed. If something has changed, that should be for the betterment of the patients. So this is my point. Hope something good happens. Thank you for the session, sir. It was so informative.
Thank you, Divya. Appreciate your input. I do understand the situation. When the PharmD program began in the US back in 1980, I believe, when I just came to this country, as it was being implemented into the hospitals and the drugstores, there were similar kind of resistance from the physicians. I don't know, it's an ego or something that pharmacists trying to stepping on their foot, but it is something that we have to deal with as a human beings in professional interactions. It does come these kinds of resistance from the doctors. Even there are few now, they do display those kinds of behavior that you just described, just ignoring your recommendations in spite of the patient being harmed. In this country, it quickly picked up for the reason because the US is a litigious society. If I am harmed, then afterwards, I can go back and question the doctor, and actually they can bring in lawsuit. That's one of the reasons the doctor, one of the reasons, but most of the doctors nowadays realize the importance of our contribution. The litigation would be a big headache. And the doctors do buy a lot of insurance in the form of a premium to safeguard their practice. That's why we do document what we discussed. When it becomes a case, a lawsuit, then those documents would work against those, unprincipled practitioners. So let's keep pushing it. I guess we need to do some talk, maybe in all the communities, to the community members, the benefit of the clinical pharmacist contribution, because it's our health in jeopardy when the doctor prescribes indiscriminately, not all of them, some of them. So that will help us, go forward in the situations. But I do understand what you mean by the situation in all these years. Maybe the some of the healthcare ministry at the central government or the PCI or IPC, those organizations may need to get involved in pushing clinical pharmacy practice, not only in the hospital, definitely into the community practice, because we got millions of drugstores there. They bring in the prescription, someone dispense it, no check, nothing at all.
Yeah, that is the scenario here.
It's not a very good situation. Anyway, thank you for expressing your opinion.
Thank you, Divya.
Thank you so much, sir.
Thank you, Dr. J. Thank you, Divya, for asking that. Divya, to give a point, add some notes to Dr. J's thought. There are a lot of positive things happening in the clinical practice in India today. In last 3-4 years, specifically during the pandemic, a lot has changed. And
yeah, true.
we had done another session with Dr. Karthik Rakam, who is again a proud PharmD professional, and he helps a lot of PharmDs again in India.
Okay.
And that video is there on YouTube. I'll search and probably send an email to you.
Yeah, sure. Thank you.
And in that we had interviewed few pharmacy professionals and who are in close touch with doctor, and they have been helping prescription audit in many hospitals. And
exactly, sir. Now the scenario, the role has been understood in the clinical sector at least a bit after this COVID pandemic. At least for at least say some, for example, at least some for 10 to 15%, I will agree. The role of pharmacist has been recognized by the doctors as well. That is only after the start of the COVID pandemic. But before that, the role which they considered us to play was something so bad. I felt like that. That's why I moved into the corporate sector. Because I was a person who was much interested in the clinical role played by the pharmacist, but due to the way in which the practitioners handled us in the hospitals during my internship and things which happened during that changed my mindset. I was much interested in clinical research and clinical sector, but due to that handling of the practitioners, I had to change my career idea and move into the corporate sector. That is a practical scenario in India.
Yeah.
But now in 3 years' time, maybe things should have changed for the better now. After the COVID pandemic, the role of pharmacists should have been understood by the public as well. So I hope for the betterment of the community.
Yeah, obviously a lot has happened, but a lot has to happen indeed. And let's hope for the best. Thank you for joining in, and thank you for sharing your inputs.
Thank you, sir. Thank you so much.
Thank you so much. Next, Dr. Ravindra Kudur. Thank you so much for joining in from US, sir, in the early morning. And please share your thoughts.
Oh, hi. Good morning from here, Manoj and the professor.
Good morning.
I have been in New York for all this time doing the same thing, like a clinical pharmacist. I just want to say a few words. That's it. I also got my PharmD, and also it was not so easy just to become a clinical pharmacist because I have a degree. Most of the time, PharmD and their clinical practice is recognized and respected because of our view and expertise. So whenever you are anybody who wants to gain their ground as a clinical pharmacist, must do a lot of homework, a lot of sweat. Every time you see a situation, go home or library and read about it, learn about it, think of different options and scenarios, and just make a suggestion what the alternatives are, instead of coming up like a professor yourself to teach the doctors.
Yes,
anyway, doctors themselves have the superiority complex, and which we cannot take them away. But more and more pharmacists provide helpful hints and suggestions to the benefit of the patients and the outcomes. The profession itself will start to grow, and that's the only time you will get our well-deserved respect. So the original pioneers like you, or all those people who feel frustration, will remain as pioneers, but the batches or the generations that come after you will reap the benefits. So there is no point in frustration today. You have to work harder, probably for less benefit for yourself. So that's my 2 cents. And I have gone through the frustration as every one of you, even in US, even with PharmD, even with working in a hospital. But after 30 years of my experience, I'm now recognized, and the doctors will really treat you as equals, not in, monetary wise, or at least in, when we sit together in conferences, they look up to you and talk to you and ask you for our input. So these things will take time. It's not just 1 or 2 years. PharmD itself is new in India.
Yes, sir.
So definitely it will happen soon. Thank you.
Thank you so much, sir. Thank you so much for your inputs.
Thank you. Thank you, Ravi.
Dr. Ravi.
Where are you located in the US?
I'm in New York and Long Island. Probably you know.
Hi, Ravi. In fact, I went to school in New York in Arnold and Marie Schwartz College of Pharmacy.
Oh, yes,
back in 1983. And appreciate your coming on the line and giving some encouraging points of view as to how the profession struggled through even here in the US. Still, there are some physicians, show some resistance to our recommendations, and it's a big wall of worry. And the thing we have to deal with the superiority complex. It's all the growing pain, but it's going to happen though as we start understanding the benefit of the clinical pharmacy. I think you appropriately explained the growing pain, and I'm sure some people in the audience would have taken that as a great pointers to go ahead and make progress little at a time, making small successes at a time, small interventions, and build on your success. And once they realize the importance of your contribution, you are going to get recognized no matter what, because they see the benefit. Appreciate your comments, Ravi. And when you get a chance, let's talk. You may also want to involve with Manoj to present some other topics of your expertise. Appreciate it.
Thank you.
Thank you so much, sir. I'll send an email to both of you and I'll connect you both of you. Thank you so much. Next, anybody else has any thoughts or questions? Please raise your hand so that we can proceed further. It's already 1.5 hours, and I don't want to take Dr. J's holiday.
It's all right. I'm good. It's only a beginning of a morning for me. Okay. It's for you guys. You got to go to sleep.
Thank you, sir. So Rachwa Mat, yeah, go on, yeah, Mat. You can unmute and ask. If you want, you can switch on your video if you want to. If you don't want, no problem.
Yes, sir. Myself, Rachwa Mat from Dava, sir. Manoj, sir. We have spoken many times. Oh, okay. And nice to see Jay sir and also Ravi sir has spoken. Their session as well. Jay sir session was very good. But I would like to say some thoughts, sir. In the government of India and the PCI, they are already approved the PP Pharma Practice 2015. According to that community pharmacy and hospital pharmacy, as well as the clinical pharmacy. But same the way, Karnataka government has also approved this one. Gazette has passed, but not implemented yet, sir. So I am working in a government sector. I am graduated from in GCP Bangalore, Government College of Pharmacy. So even though I am doing some training in that clinical pharmacy, so I have studied a little bit. But I heard sir some errors in the prescription. Yes, sir has said ciprofloxacin BID doses. In the pandemic, I have saw so many irrational uses of the medications. Even though we all know about the after post-COVID research study has told some in India, so many people they are died from phobia and also irrational uses of the medications. As you know, sir, azithromycin has dumped a lot. Some of the doctors they have prescribed BD and TID doses also instead of writing OD doses. These things are so many without prescription. So many people they have taken the medications. All those things happens in India. But the people we know very well about the medicines, what to do? This is the situations happening in India. So something we have to do change in the India, but we are doing the writing letter to the government also, better implement as well as early in the government sector also, in the all the field, actually in the community pharmacy, hospital pharmacy, in the government sector as well as the private sector. As you said, sir, in the metro cities, some of the hospitals, they are adopting only clinical pharmacists. They are taking recruitment, but in the so many, yes, sir, I'm very much wonder in the America, US also, they have so much of a superior complex in the doctors. Uh, in India, it's a huge, sir, as well as the law, bar council and the medical council. Uh, we cannot speak anything else. Like so, in the pharmacy sector, I'm speaking means clinical pharmacy and community pharmacy. Basic education, that diploma in pharmacy has uh, to be have to improve a lot. Means so basic education is the graduation. It is better. I thought, sir. So anyhow, okay. Thank you, sir. Thank you, Manoj, sir.
Thank you, Mat, for your thoughts. We just hope that more rights are given to the community pharmacist at the government level, and you are allowed to, interact with the doctors more frequently and help the patients get better medications. Thank you so much for your thoughts, and we just hope things, become better with each passing day. But yes, in private, lot of things have changed. Sorry to know about the sad affairs in the government sector. And yes, the minimum qualification criteria also needs to be improved, upgraded to at least B Farm or Farm D at the community level, so that we can see better effect. Dr. J, you will have some thoughts on this?
Thank you, Raji. You guys are better informed as to whom to contact back in India. My knowledge is so little. All I know is, Health Ministry of Health, and also that IPC, Indian Pharmaceutical Association. Those are the organization I think might intervene and make some changes in the regulations, so that not only all the hospitals should have a clinical pharmacist, even the drugstore should be equipped with pharmacists present at all the time, because a lot of elderly people coming in and filling those prescriptions in millions of drugstores, and they are not getting the right of being treated correctly. Thank you so much, Rachaya.
Absolutely. Thank you, Dr. Jay. Thank you, Rachaya, for that. Divya, you want to speak again? I'm just giving you the unmuting right.
Actually, I wanted to say what the other person who spoke next to me said was exactly right. But I don't want to argue with him on that. But I would like to say the role being played by clinical pharmacist is well understood in his place. But it is not in our country, India. That is what I wanted to stress on. Because the same scenario happened when I was in college, when I was doing my internship and everything. People used to come to my college from US, and the scenario which they explained was completely different. And I would imagine myself being in the US or somewhere else outside India, playing the role which they played there. But the point which that sir said was exactly right. But the scenario in India is not that. It will take time, but I guess it's been 10 years since this course came to India. I'm not sure about the year exactly. But he said it took 40 or 50 years. I don't remember exactly the number of years, but maybe we have to wait for it. Maybe we are the pioneers in bringing it in India. That's it. Thank you, sir.
Thank you so much, Divya. Yes, indeed, we'll have to wait and we'll have to do our bit.
Yes, but maybe I'm happy to say that we are the pioneers in that. Thank you.
Thank you. So we don't have any more questions, I think. Dr. J, let me just have a look at the chat if I have something.
I think Dr. DK had a couple of questions, Manoj. I was glancing through the chat.
Okay.
One of them was using doxycycline for UTI. Doxycycline, of course, is one of the antibiotics that is appropriate. Even for the complicated UTI, doxycycline is a very old drug. It's a good drug, but there are better drugs available in the armamentarium. Doxycycline, they have the issue of drug interaction with food and antacids, any milk products. So people may be taking some antacids, drinking some milk. So there is a physical interaction that the milk product antacid may absorb the doxycycline and reduce the efficacy. So, but still it could be used, addressing all those interaction concerns and dispensed appropriately. I believe he asked for my email contact, which I put in the email box. Anyone feels to send some message inquiring about clinical pharmacy, or you can contact Manoj as well. Yeah.
Sir, definitely, sir. I'll share the email ID and also the LinkedIn profile link of yours to everyone who is present in the session. And there is one question from Ramshad.
That'll be great.
There is one question from Ramshad. He says, is it okay to give medicine where recommended frequency is 2 times daily, but the doctor gives the same medicine 3 times daily? Since maximum recommended dose is allowed them to prescribe such frequency.
Oh, I see. Yeah, we discussed the example of the Cipro.
Yeah.
Cipro is normally Cipro, Levaquin, or levofloxacin. They're all prescribed appropriate doses. Cipro is given twice daily normally, and levofloxacin is given only once daily, although it is the same class. Because of the half-life of the antibiotic, you don't have to repeat the Levaquin. It has got a long half-life when you compare to ciprofloxacin. That's why one of the advantage of when you select a fluoroquinolone, you might as well select the levofloxacin, which is given once a day. Easy for the patient taking once a day from the compliance perspective. But definitely if they're prescribing inappropriate prescriptions with incorrect dosing schedule, it's one of our responsibility to make sure that is addressed. Do call the doctor, advise that this dosage is inappropriate, present the evidence, push them. You got to push it. You got to earn it. It's not an easy path, especially in the beginning. Even in ciprofloxacin, although it is given twice daily, in renally compromised patients with compromised creatinine clearance, you have to reduce the dose. It's not one dose fits all. Like, one shoe does not fit everyone. It has got to be cut accordingly. So most of the drugs are clear renally. So there is a separate discussion on renally clear drug and how to adjust the dose. They all changes. Hope that answered the questions.
Absolutely, sir. Ramshad is not there now, but anyways, the recording will be available. So anyways, to all the members, thank you so much for being part of our session today. I don't see any more questions. And with this, would like to close the session for today. And we'll be back next Saturday again with some more information. And please do fill in the feedback form, which the link I already have shared with you. And those of you who have registered for tomorrow's learning session, please do attend sharp at 2 o'clock. So we have this learning session happening for the past 21 days. And this is on digital literacy. So those of you who have registered, we'll meet tomorrow at 2 o'clock and we'll continue our learning. So thank you so much, all the participants. Thank you, Dr. J, for your time and so much of information that you have shared with us. I'm sure this will be helpful to our pharmacy professionals and help them become a better professional in their lives. So thank you so much, Dr. J. Would you like to give a final note before we end the session?
Okay, thank you, Manoj. Appreciate it. And also do notice that you have Googled up and put in the chat on the QT prolongation. Excellent work. And I like working with you, particularly because of these additional clarity that you provide, not only in terms of communicating through Zoom on the topic, an intervention in my presentation, adding more clarity. Appreciate that. And we will try to do at least once a month to begin with for this year, if not twice a month. But it is all important that audience and the schools and the institution, if they have some topic to discuss, we should get it so that you'll be able to pick and choose the most useful topic and go from there. And I thank you for all of you to coming on a New Year's Eve. I was going to stay a little late last night. Some other friends came over, but I'm done with one drink and went to sleep at 11 o'clock. To be ready in the morning, you say. So I'm going to do my best as I can. When I come to India, maybe I'll try to meet with you, Manoj, in Bangalore.
Definitely,
and some of the friends, if I can. Probably organize some kind of a meeting in some place.
Definitely we'll do that.
Yeah, thank you so much. And I thank everyone who participated.
Thank you so much, sir. Thank you for your time. And I appreciate everyone's time. Thank you so much. Rahim, Dinesh, Divya, Guru Kiran, Harshita, Jain, Karishma, Neha, Nisha, Rachaya, Ramesh, Kudur sir, and Sandeep, Shivani, Shwati, Varsha, and Vishal. Thank you so much for being with us till the end of the session. And some of you will meet tomorrow at 2 o'clock sharp, 2 o'clock afternoon sharp, and continue our digital learning. And again, on Saturday, coming Saturday, we'll meet again and explore some new topics. Please fill in the feedback form and share your thoughts. And also let us know if you would like us to arrange for some sessions on some specific topic. I'll try to connect with some speakers I am connected to. And if you have some suggestions on some speakers, please do let us know. Let me know. I'll connect with them and try to bring them on Zoom sessions like this and help us learn something new. So the objective is to keep learning and keep growing, and without learning, nothing really happens. So thank you so much for your time, and I appreciate your attendance till the end of the session. And with your permission, Jay sir, and with everyone's permission, I would like to end the session. All of you who have registered for today's session, you will receive an email with the recording copy, and you can go multiple times and watch the recording and clarify the doubts. Just in case you feel that there's something else to be added in the sessions, please do write back to me, and we'll see what best we can do. So thank you so much. Clinical research we have already done. Divya, please watch that on YouTube. I'll send an email to you later on. Clinical research, medical writing, pharmacovigilance, all of that is done. But yes, I'm planning for the version 2 of all those. I'm looking for some speakers. Already I have about 20 speakers ready for this year, but then I'm looking for more speakers, and we'll plan to organize this more frequently. Thank you again for all of your time, and we'll meet again next week. Thank you so much, Dr. J. Thank you from the bottom of my heart, and thank you so much.
Manoj. You're welcome. Thank you.
Thank you.
Happy New Year.
Happy New Year, sir. Happy New Year to all of you. Thank you.